Did you cite your focus or were you the one that put you?
Yeah, CDC for all of it.
Okay, I think honestly we should just cite the CDC instead of each individual case to the CDC to save space. Because if we need.
That's what I was wondering, because I was like, I don't feel like you need to each one with and.
Yeah, all of it, we just use the CDC.
They just cite the CDC.
Yeah, just one different one. The other ones are all through the CDC.
Okay, yeah, then I would do that.
Riley, back from the dead. Better?
Yeah.
Now Dawn's sick. And I wondered if she should blame you, but that'd be too easy. Gracie, all by yourself, are we? Because your whole row is sick. Well, that's okay. All right. Good morning, everyone. Hope your weekend was stellar. As you discovered, we have a lot to cover, and we only have 3 lectures left. So I'm going to try to kick it into very high gear so we can get as much of this done as possible. Some of this may need to be podcasted. If it does, I will let you know on that. So Kylie's better. Welcome back. And now Dawn's sick. So I sent her the link, so maybe she'll join us. And according to Reagan and Emma, the Wi-Fi at the hotel is very spotty. So if they take a little longer to join us, that's probably why. It's causing havoc with the Connect assignments as well. A couple of you have had a lot of trouble with Connect, and I have an idea. We'll chat about that after lecture. We'll see if my idea will work. Lorna, why they said, oh, just have him go open it. So here's what would happen if I reopened it. I'd have to cancel it. That means everybody's grade gets wiped out, reissue it, and then reopen it, and then everyone would have to retake it. Those technicians know that. Why? The HE double hockey sticks, they would tell you, oh, he just needs to reopen it. I don't know. When they bloody well know, that's what I'd have to do. No, that is garbage from the back end of a horse. And they know that. I just, guys, come on, don't make this stuff up as you go. They've got, if you logged in and started taking it, they should have some record of it. Bull, you logged in and started it. It just means you didn't finish it. If they go through the logs like they're supposed to, which is hard work, work, that 4-letter word, they'd know that. So don't give me that. That's horse manure. That's complete horse manure. Now, and that's why I told you to call them, because if I call them, well, your student has to call us. Gee, thanks a lot. You're really helpful. Okay, now that I had that rant, let's pray and we'll get started. Father, thank you for the rain. Thank you for the way it nourished the ground, made everything good and wet. We pray that your presence and that your word would nourish us every day, even today, Lord. Your word in creation, even your word through the curse of disease, would speak to us and nourish us as these young men and women trained to be healers. Watch over us today, please. Help those of us who are ill get well. Thank you for this time in Jesus' name. Amen. All right, HIV. So HIV is a retrovirus. It has an RNA genome. It reverse transcribes that RNA genome into DNA. It uses the enzyme reverse transcriptase to do this. Reverse transcriptase. Very unusual enzyme. transcriptase is only found amongst the retroviruses. However, there is another virus that has reverse transcriptase, and that is hepatitis B. Now, this means some of the drugs that are used to inhibit the reverse transcriptase in HIV can also treat hepatitis B. And sometimes, well, actually often, HIV patients will be co-infected with HIV and hepatitis B. And that's the beauty of this. Several of the drugs can hit two viral birds with one pharmacological stone, if you will. So the virus is transmitted through bodily fluids, blood, genital secretions, and breast milk. It is not present in sweat, not present in urine, not present in feces or saliva. Early in the 80s, when this was coming out, and there was the acceleration of data as Montagnier's lab and the Gallo lab here in the States identified the virus, sequenced its genome very quickly. There were all kinds of papers saying the virus has been isolated in saliva and sweat and so on and so forth. Those reports turned out to be bogus. So most common mode of transmission is sexual intercourse. However, it can also be transmitted through blood transfusions, but because screening now is so much better than it's ever been, transmission through blood transfusion is rare unless they receive their blood transfusion in a third world country where screening is either non-existent or poor. So we'll put blood transfusion in here. And we'll say maybe. In California, there was a very famous politician named Howard Jarvis. Howard Jarvis was the author of Proposition 13 that essentially got rid of corporate property taxes in California, which meant that the politicians could raise all the other taxes in order to pay for the very generous welfare state that state has. Howard Jarvis died of AIDS because he received it in a blood transfusion after he had had surgery. So most common, most efficient mode of transmission is male to male sexual encounters. Male to female, female to male can happen, but they're not as common. Despite what you read in certain inserts and things like that, it's just not as common. Female to female transmission is rare. There are documented cases of it, but it is rare. We should also say that HIV can be passed from mother to baby. This occurs during birth because during birth, the baby is exposed to the mother's blood. However, it's clear that pre-exposure treatment of the mother that knocks the viral load down can prevent this. So let's just say preventable. But you've got to be aggressive about treating it, knocking viral load down in the mother. And some of the drugs are very safe for mom and baby. Some of them aren't, but some of them are safe. All right. Surface glycoproteins, it's a P160 that gets processed into two glycoproteins. Glycoprotein just means the protein has sugars attached to it. A P120, a P41, they make a complex. That's what this knobby dude is supposed to be here. The complex of GP120, GP41. It binds to the surfaces of T helper lymphocytes. It binds to the CD4 CCR5 complex. CCR5 is a chemokine receptor complex. If someone has been infected for quite a while, this glycoprotein will start to change. In response to this, the T cells will start to downregulate CCR5. So now the mutations that the virus experiences in your body will now make it so that this will not bind CD4, CCR5. Now it binds a different chemokine receptor, CD4 and CXCR4 co-complex. That's what happens later. This can tell you how long someone has had HIV in their body. If their HIV infects this group of cells rather than this group of cells, it tells you it's been a while. So if HIV is left untreated, it will progress over time and it will result in 4 different clinical stages. The first stage is the acute stage. The acute stage. Stage 1, the acute stage. This initial or primary infection is typically mediated by what is called the R5 strain. And that R5 strain uses a CD4 CCR5 co-complex. Incidentally, there are rare individuals who have mutations in the CCR5 gene. They make a CCR5 chemokine receptor that is very, very different, and those people are intrinsically resistant to infection by the virus. And in fact, in a paper, a very interesting paper that was published 2012, I think, one of these individuals donated their bone marrow to an individual who had very serious HIV/AIDS. And to do a bone marrow transplant, you have to suppress the immune response. This guy's immune response was already on the fritz. He got bone marrow from this dude with the CCR5 mutation, and his body then eventually cleared the HIV from his body because it couldn't infect any of his T cells. That's how important this co-complex is. So the acute phase uses the CCR5 co-receptor to infect both T cells and macrophages. Near the infection site, during this initial period, the individual is infectious, but usually the virus has not replicated enough to be detectable in your commonly used HIV tests. So this is called the so-called window period. Window period. Virus is just too low to be easily detected. So individuals might get tested, but they can have a false negative test. The window period usually lasts about a month, but it can range from 10 days to 3 months. So it can range 10 days to 3 months, and the average time is 1 month. That's a number I'd like you to remember. 10 days to 3 months, average is 1 month. Say that with me. 10 days to 3 months, average time is 1 month. I don't think you believe me. Say that with me again. 10 days to 3 months, average time being 1 month. A lot of you are going to take care of HIV patients. So this is stuff you're going to need to know. Now, during the window period, infected cells will start to migrate from the site of infection to their regional lymph node. In that regional lymph node, there are lots of immune cells that live there. And this leads to a big spike in HIV replication. During this big spike in HIV replication, T cell numbers are going to degrade and decline dramatically. Dramatically. And at a certain point, the virus will replicate so much that the window period will end. And now HIV tests can detect the infection. And now HIV replication will continue to increase until it peaks at about week 6 of primary infection. 6 weeks, again, it's about plus or minus a week or so. At this point, the individual will start to experience flu-like or mononucleosis type symptoms. Very, very indescript. Fever, very tired, fatigue, run down. They'll have swollen lymph nodes and joint or muscle aches. So it's like you have the flu, essentially. Symptoms will last about 2 weeks. So we have flu-like symptoms. That's about 2 weeks. And during this time, the immune system now is starting to mount a counterattack. And it will start to control the viral replication. So that big spiky dude, lots of replication is going to start to decline. And the T cell counts will now start to rise again. And during this period, T cell counts will usually start to get to normal. Normal is going to be over 500 cells per minute. 500 cells per minute. Now, the immune system has fought back, but is the virus still around? How do we say the virus infects cells? It integrates into the genome of the host cell. So is the virus still there? Yeah. Yeah. It's in the genome of infected T cells. So even though the immune system is counterattacked, the virus is still there. And it's going to very slowly, gradually kill off T cells. So your T cell numbers, which bounce back up, are now going to start to do this. So the T cell counts go up, virus declines, and now you start to get to that second stage of HIV, and that's the chronic or clinically latent stage. The chronic or clinically latent stage. So this is stage 1. Stage 2 would be the chronic. This stage can vary tremendously. Can last anywhere from 2 to 10 years. And then I'm going to say ish, because that can vary wildly. It's not uncommon during this time for the T cells to hover between 350 and 500 cells per milliliter. So there are enough T cells to fight off infections and remain asymptomatic. But as the virus slowly replicates within lymph nodes, T cells are going to gradually start to decrease. The immune system will progressively weaken, and now certain dormant infections will start to emerge. Can you guess what some of those are? Come on, gang, it's not that early. Well, okay, it is, but still. We talked about one group of viruses that's really good at latent infections. Remember what group that is? Starts with an H, ends with a P's. P's. HSV1 can hide in the trigeminal ganglia. It can cause sores on the lip. If you have HSV2, usually you can get genital herpes. So you can start to get HSV infections. Or if you've had chickenpox, now you can start to get shingles. And then all of a sudden you start getting outbreaks of these viral infections. People at this time also are very, very susceptible to tuberculosis. People living with HIV are more susceptible to community-acquired pneumonias. Tuberculosis is one, the other is Streptococcus pneumoniae. Reverse transcriptase that replicates the virus is very, very error prone. So as the virus replicates, it will make copies of itself that are very different from its parent. This keeps the immune system guessing. Eventually, the virus will start to make versions of GP120 and GP41 that no longer recognize the CD4-CC5 complex. Now they recognize the CD4-CXCR4 complex. And this is now called the X4 strain. The X4 strain. That will arise during this chronic or latent stage. And now we start, as the T cell numbers start to fall, now we get to stage 3, which is the symptomatic phase. Now the T cell count is between 200 and 350. Now you're going to start to see infections that you don't normally see in healthy people. One of the big ones will be oral thrush. This is caused by Candida albicans. Remember, I showed you Candida albicans in the lab. It's a yeast. You'll get this whitish, yellowish stuff on the tongue. You can scrape it off. The patient will usually have incredibly foul breath. They'll also have it on their mucous membranes. They may even have it in the esophagus, bless you. And it can be very, very noisome. I yield fact, Candida albicans is treatable with antifungals. There's another strain called Candida auris that you're starting to see in HIV patients that's very drug resistant. It's very hard to get rid of. To identify the two, there are good PCR tests you can order. That's not a beastie you want to mess with if you can help it. Now, if they get some sort of film on the tongue, you cannot scrape off. We talked about that actually in pathophys. That's called oral leukoplakia. Oral leukoplakia is caused by Epstein-Barr virus. We'll also see that in the symptomatic stage as well, because that's another herpes group virus that tends to be latent in our bodies. Also, during this time, you'll start to see a specific skin tumor pop up. This will look like violet plaques or splotches. If you biopsy them, they'll be full of lymphocytes, and it's usually overgrowth of endothelial cells in the vessels of the skin. This is Kaposi sarcoma. Kaposi sarcoma. Finally, people also in this stage will tend to develop genital warts if they have human papillomavirus, usually in places, and that's caused by HPV, papillomavirus. If the T cell count falls below 200 cells per milliliter, so let's rehearse. Normal is above 500 cells per milliliter, and that's in what? Your shoe, your what? That's in blood. Blood. So getting a T cell count on HIV patients is very important. That's a relatively easy test for you to run, because literally you take the blood and you drip it through a machine, and the machine will tell you the number of T cells. Once you go between 500 and who? 500 and 350, that's latent phase. Between 200 and 350 is the symptomatic phase, and then below 200. Now you're going to start to see lots and lots of infections that are the result of a person who has a compromised immune system. So you'll see persistent fever, fatigue, unintentional weight loss, and diarrhea usually. And now the person has started to enter the last phase, and that last phase is the immunosuppressed phase. Now your T helper cell count. Remember, these are CD4 positive cells. Below 200 cells. Usually it's reported in your lab results as cubic millimeters. Cubic millimeters in a milliliter are the same thing. There are lots and lots and lots of different infections that these people get. One of the defining infections, as we said before, is pneumocystis pneumonia. Pneumocystis pneumonia. That's caused by Pneumocystis urovecii. So you get Pneumocystis pneumonia. Because most of us have JC and BK virus in us already, these can now infect the central nervous system and cause the progressive multifocal leukoencephalopathy that we talked about before. And if the T cell count falls even lower, say below 100, now you're going to start to get infections with just household fungi. You'll get aspergillus infections in the lungs. Another opportunistic parasite they'll have is toxoplasmosis. You'll also see a GI infection with a protozoan. You almost never see in people with a healthy immune system, cryptosporidium. In an HIV patient, this can cause a life-threatening diarrhea. Cryptococcal infections of the brain can also be an issue, and then also cytomegalovirus infections can cause a variety of issues. It can cause colitis, encephalitis, pneumonia, esophagitis. Yeah, there's just a whole list of infections these folks can get. All right, so diagnosis, typically you're looking for viral components. You're either looking for the components or you're looking for antibodies to the components. If you're looking early, you haven't raised antibodies yet. So very early tests are not going to look for components, but you're usually looking for a component of the virus. There's a component of the viral capsid called P24. A lot of your early tests are looking for P24 protein or antibodies against P24. Antibody tests also can tell you that you were exposed to HIV. They may not tell you you actually have HIV. If you have components of the capsid in your blood, yeah, you have HIV. If you have antibodies against it, maybe you have it, maybe you don't. So be careful with antibody-only tests. Definitely the most sensitive test looks for the viral RNA. And these are nucleic acid amplification tests. They use PCR. These tests usually can detect very small amounts of virus in the body, and they can usually detect it very early. So PCR tests are your earliest, easiest tests. Also in babies, maternal antibodies can cross the placenta. So if a baby has antibodies against HIV, baby might have gotten those from mom if mom's infected. Doesn't mean the baby has HIV. So antibody-only tests can fool you. Antibody-only tests can fool you. All right, so when it comes to treatment, it's a combination drug treatment that's used. Virtually all of your cocktails of anti-HIV treatments, and this is called your highly active antiretroviral treatments or HART treatment regimens. Virtually all of them have drugs that inhibit reverse transcriptase. Virtually all of them. Nowadays, the integrase inhibitors combined with a reverse transcriptase inhibitor are usually the best ones. They're best tolerated. Turns out integrase inhibitors not only are very effective, but they're very well tolerated. So it's usually a cocktail of those. So I have a little mnemonic for you for the 4 stages of HIV. Ready? It's the 4 F's. Flu-like symptoms, feeling fine, that would be the latent period. Flu-like, that'd be the acute stage. Flu-like symptoms, feeling fine, falling count, that's the symptomatic stage, and final crisis. Flu-like symptoms, feeling fine, falling count, final crisis. I came up with that on my own. Are you proud of me? That's okay. That one's free. HIV treatments today are oral, and they have to be taken consistently. If you have a homeless person you're trying to treat, they're not taking the medicine consistently, it's not going to work. It has to be taken consistently. There are IV cocktails now where someone essentially can load up IV and then they're good for a month or so. Let me give you a clinical vignette to give you an idea of what a patient with HIV may look like. David comes into your clinic. He's a 42-year-old man who has a fever associated with a cough and difficulty breathing. David mentions he's HIV positive. Click, 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 click. Blood test. You decide to run a blood test. His T cell count is 180 cells per milliliter. Should you be worried? Yes, you should be worried. It's below 200. He's in that immunosuppressed period. He asked for a chest X-ray. The chest X-ray shows gray, hazy-looking areas in both lungs. He probably has pneumocystis pneumonia, which is very treatable usually with sulfa drugs. Here's a second one. Charles, 32-year-old man, is referred to the clinic by his dentist. His dentist detected white plaques on both sides of his tongue. And when you try to scrape the plaques with a tongue depressor, they can't be removed. Oral leukoplakia. Upon further questioning, Charles tells you, even though he has not been exercising or dieting, he's been losing a ton of weight. Should you be worried? You should be worried. You run an HIV antigen antibody test, and it's positive. So he is probably in this stage. Those are just 2 examples of people with HIV. All right. Okay, right. Questions? Yeah, Grace? No. The disease is kind of like pregnancy, and that is very individual, and no 2 are the same, so to speak. Some people, when they get infected, are very healthy, and they won't know they have it. Now, people are screening. Usually, so say, Grace, for example, let's say you go work for a doctor's office, say you do family medicine, just to pick something out of the hat. You will screen usually your patients on a regular basis, whether they need it or not, for HIV. And so it usually gets picked up. So my doctor, I'm not in a high-risk group. And so he said, just take an HIV test to humor me. So I took an HIV test to humor him, and it was negative. And now every time it comes up that I have to have one every 5 years or something like that, he just takes his computer and says, okay, yeah, we get that. Because I don't use intravenous drugs. I don't practice male-to-male sex. I very wonderful sexual relationship with my wife, and that's it. And I'm not in a high-risk group. So he just doesn't bother with it because it's a waste of everybody's time, resources. But now because there's all this screening, especially if you're in a high risk group, then even if you're in this latent phase, it'll be picked up. And then you'll be treated. And if you're treated, it keeps you in that latent group usually pretty well. And it can keep you in a latent group for quite a while. Some people may dip into the symptomatic stage because their HIV starts to become resistant to the drug cocktail they're on. But then you switch drug cocktails and usually they go back into the latent phase. HIV treatment has come a long way since the days of AZT. So Grace actually brought up a really good point. You can get people who dip into one stage and then you can fight it back to another stage. As you treat them, knock their virus down, their immune system can recuperate. Keep in mind when you've treated the HIV aggressively, the immune system starts to reconstitute. They can experience something called IRIS, immune reconstitution, immune syndrome. The immune system now all of a sudden gets very active, and all these microbes now in their body start getting killed. And so their body just reacts. They have this massive inflammation and they can get very sick. But that getting very sick can actually be a good sign. Unfortunately, they can get so sick it can kill them. So you have to be very careful about IRIS once their immune system starts to get reconstituted. All right, endocarditis. Any more questions about HIV? All right. So when it comes to the heart, if you have an infection that is temporary, and the cells happen upon your heart valve, there are certain microbes that can actually do a pretty good job of sticking to heart valves. If they stick to the heart valve, they can cause a condition called infectious endocarditis. And that condition is called infectious endocarditis. Now, here's the rub, if you will. What if your heart valve is damaged by some sort of previous event? A damaged heart valve has been roughened. If you roughen the heart valve, now that heart valve is going to be much more likely to have something stick to it. And if it's much more likely to have something stick to it, then you are at increased risk for infectious endocarditis. Go. Okay, this isn't funny. So the risk factors for infective endocarditis would include if you've had previous infective endocarditis. The big one is if you've had rheumatic fever. Rheumatic fever. So with rheumatic fever, you had a streptococcal infection. That streptococcal infection caused you to make antibodies to the streptococcal cell wall. The streptococcal cell wall has this protein called M protein, M as in mutant. Antibodies against M protein cross-react with heart valve tissue. That immune response against your heart valve tissue causes the heart valves to become inflamed and swollen, and they leak. The heart valves will heal, but that leaves the heart valves now roughened. And if you roughen the surface of the heart valves, now microbes can stick to it much more effectively. Can I erase this? Advancement keeps showing us pictures of the new building refit as they raise money for it. The architecture's good stuff, and all the rooms they show us, I keep saying the same thing. We need more Blackboard space. More Blackboard space. UC Irvine had these things 4 blackboards you could pull down. Those were wonderful. Just like you fill it up, pull one down. Fill that up, pull one down. Be great if we had those. Of course, one day I'd fill it up and Blackboard got stuck. Something was wrong with it. Turned out some idiot had taken their gum and shoved their gum up into it, so it got stuck. Yeah. I'd love to get my hands around the throat of the person who did that. But truly, I would. All right, so rheumatic heart. One of your biggest risk factors for infective endocarditis. Secondly, if you've had a pacemaker inserted or any sort of valvular or congenital heart disease. That's heart disease. Or non-cardiac factors like intravenous drug use. Having non-cardiac. Also having some sort of intravenous catheter. Remember, there's these microbes that can make biofilms on these catheters. Those biofilms can detach. They can get stuck to a roughened heart valve. Also, immunosuppression. Or recent dental or surgical procedure. Cardiac, non-cardiac, we could also put in here a pacemaker. So clinically, infective endocarditis can be categorized as either native valve, or prosthetic valve endocarditis. So native valve means that it's infecting your valve. You don't have any sort of artificial valve in there. Native valve endocarditis is caused usually by Streptococcus aureus. Sorry, Staphylococcus aureus. Or viridans streptococci. A lot of you isolated viridans strep from your throat, I noticed. Staph aureus is mainly seen in intravenous drug users. Since these bacteria are usually in the skin, usually with intravenous drug abuse, the staph is going to affect the right side of the heart. Which valve is the one on the right side of the heart? Right atrium, tricuspid, left atrium, bicuspid. I'm the king of stupid mnemonics. So it's going to be that tricuspid valve usually that Staph aureus is going to affect. Why do you think it affects the right side if you inject yourself? That's where it goes first. Yeah. Yeah. Aaron's absolutely right. That's where it goes first. That's where it goes first. Viridans strep typically are going to come from dental procedures. If you've had a dental procedure and you bite down, you're going to stretch those vessels in the tooth socket. And viridans strep, which are very common in the oral microbiome, are going to get in. Viridans strep make dextran capsules. Dextran capsules are really good for sticking to your teeth, but they're very good also for sticking to your heart valve as well. Prosthetic valve endocarditis, usually it's going to be Staph aureus. Usually, there are exceptions, but usually. Because of Staph aureus, you have to be careful that you might have methicillin resistant Staph aureus. And that one is harder to treat. Drug of choice for MRSA? Come on, gang. I say MRSA, you say? You take the church van to church? The van? Vancomycin. Vancomycin. All right. Signs of endocarditis are fever, fatigue, dyspnea, and weight loss. Fever, fatigue, dyspnea, and weight loss. Upon exam, something you're going to usually see is a new heart murmur. What kind of murmur you going to get? Well, it usually differs, but the one that's the most common is aortic valve regurgitation. Because it was all last year when we talked about the murmurs, very briefly, aortic valve regurgitation causes a decrescendo blowing diastolic murmur. So it's kind of the opposite of aortic stenosis, which causes a crescendo decrescendo systolic murmur with a systolic click. This is a blowing diastolic murmur. You're going to best hear it at the left sternal border. Now, when you get stuff growing on the heart valve. Little growths on the heart valve are called vegetations. What kind of turbulence do you have around heart valves? High or low? High. Can those vegetations break off? Yeah. Not only can they break off, they often do. Now you've got these clumps of bacterial cells floating around in your vessels. Can they get stuck in vessels? They get stuck in vessels, you're going to have little tiny infarctions. So you'll have septic emboli. One of the places they'll lodge is under the fingernails. So one of the things you're going to see are splinter hemorrhages in the fingernails. They're called splinters because they're little long things like a splinter. And you'll see them usually just kind of a one or two, or maybe a cluster in fingernails or something like that. They're very easy to see. You will also see all flat, painless red spots on the palms and hands and the soles of the feet. These are called January lesions. These are painless. You often see them with the splinter hemorrhages or just those. Then you start to make antibodies against these bacterial clumps. Now you get antibody antigen clumps that are going to lodge in tissues. And these will deposit in the fingers and the toes. These are called Osler nodes. On the pads of the fingers and toes, these are painful. Janeway lesions are not painful. Osler nodes are bigger and they're painful. You will also, on a examination of the retina, you'll also see deposits in the retina. And these are called Roth spots on the retina. These can also deposit in the kidney, and they can cause glomerulonephritis as well. All right. So the causative agents, as you see, typically in Staph aureus. Strep pyogenes is usually going to be in children. Monia would be down the list. Of those, enterococci will be the cause if someone has had GI surgery, usually. Pseudomonas aeruginosa will be the case if someone has had a previous Pseudomonas infection, usually because of a burn or because of an ear infection or something like that. Diagnosis. Diagnosis can be hard. So we have the Duke's criteria. So this is a very good spot to stop and take our break. We'll come back, we'll mention the Duke's criteria, and then we will move on from there. Take 5. Our ladies have practice this morning.
After 16 on that didn't show up for me. And it says it's already graded. And I checked all the grades. And on Monday when it said it was due, and I never. Very safe for real. Is that?
I'll take a look at it, give it a shot. Reagan said she was having trouble doing it too.
And so I told him that's great.
Because
And it said it's
there were, yeah, people were having trouble with it. And so I reissued it.
close to 27. But we didn't even finish 6.
No, I changed the due date.
That's what it says on mine. I had 9 for 16.
And you never opened it?
No. Because it didn't show up for me.
May have to delete it and then completely redo it if that's the case. In which case, anyone who's taken it will have their grade expunged.
So 12, 13, yeah, 12 and 15 showed up with the grade. So I did those. Yeah. And I had been looking for 16. I even looked on Monday when it said it was due on my thing, and it never showed up, and now said it was due. Which is like, you know, weird that it's due. And then I looked down and I was like, oh, 16 there, and it never showed up. Yeah. Are you guys on like your other school?
Okay. No.
Here's my idea.
I'd rather have that than not. I would rather. I know how it is.
Yours is very hit and miss. You know, 3 that you've done,
Yeah.
the 1 that you missed, 4 that you've done, 2 that you missed, 5 that you've done, 1 that you missed. It's screwed.
That's why I was thinking the one type of girl, she never keeps doing about that.
I think if you started and then your internet kicks you out, I think it says that you've done. The thing is, I give you no chances to do it. And it should just let you, that should discount that as one of your chances. And then just let you that up. And then you get it close.
No, wait, plus it was busy and then like. So I think I was like, no, it was under 2. I don't think it was.
Like you just like restarted it.
When they say stuff like that, I just want to reach for the phone. And choke them. Oh, that's gonna screw it up a little bit.
I know that's the one that I was shooting. Unless I did.
I just want to get this. Well, we have no record that you did. No, you do have a record that you logged onto it. Just check the records. Check the login records. It's just. Okay, Grace.
The project's cool.
You guys having trouble with 16, chapter 16?
Like, I didn't get it done tonight because the soccer girls still have to.
You took it, you had to record it? Because Reagan are having terrible trouble with 16. And they're having trouble with
Yeah, it
16.
didn't show up for me at all.
I might end up having to delete 16 and then reissuing it because,
16 is.
see, Lorna can't even bring it up.
No,
It doesn't even come up for
it isn't like there at all, like,
And-
it,
Reagan and them are having similar trouble.
I just get the 17.
So you guys all took 16 and it was fine. I do not get this. I'm thinking Connect. Connect is having trouble with certain operating systems, I think. Lorna, Lorna, do you do your Connect on your iPad?
But she was just explaining that maybe I have to go to different folder for some reason.
Yeah. The thing is I've never had to go to a teacher like this, it's the only one. Oh, yeah, I don't tell them to do.
I don't get what the issue is. Okay, gang, let's get back on the horse.
Dr. Reed, I have a quick question. Are you gonna do our final the way you did Tableau last year?
Yeah.
Okay.
Yeah.
And use our wood this one?
Yeah.
Yeah.
Mhm.
Okay, just want to show you some of these. This is what an Osler node looks like. Can we agree that that's hard to miss? These are painful. You push on and the patient's going to go, ow. Don't do that, you beast. These are Janeway lesions. These don't hurt, but you see stuff like this, you might think that they fell on their hand and caught themselves. It looks a little bit like a scrape, but it's not. And then splinter hemorrhages can be something as subtle as this, or they can be something a bit more obvious like this. You look at stuff like that and you might think, oh, they're barbecuing and something, you know, got on their fingernail or something like that. If they have these on multiple fingernails or on their toenails, Katie, you start looking at your fingernails if you have those. No, you don't. Stop. These are what these splinter hemorrhages look like. So this is what you're looking for. Now, can we agree this is subtle and you can miss this? So what are you going to check in a checkup? All their fingers and toes. All their fingers and toes. And that's what you're looking for. All right. In order to properly diagnose the condition, you have to isolate the organism from the blood. So you have to do so-called blood cultures. Now, this always causes students to drive into the ditch. When I say blood culture from laboratory, you're thinking, oh, you just collect some blood and you streak it on blood auger, right? No, that's not what that means. Blood culture is a specific liquid culture. It's blood-based. It's in a sterile bottle. You have an IV line. You draw blood from that IV line. And then you do 3 sets of cultures. You do one for aerobic bacteria, one for anaerobic bacteria, and one for fungi. You put 10 milliliters of blood in each of the culture. Very often, you can have organisms in the blood, but they don't come up on the culture. So if you look at your Duke's criteria, Well, notice you have major and you have minor criteria. Major and minor criteria. So the clinical criteria, you have 2 major criteria, or 1 major and 3 minor, or a bunch of minor criteria. So if you flip it around, it will show you the major and the minor criteria. And these were revised in 2023. What you have here is early 2023. They were revised in August of 2023. And I tried to get the table to download, and the blasted website wouldn't let me download the table, bless you. And I tried printing it out, and I needed a subscription, and I needed to pay them $5,000 for a subscription. And I told them to go pound sand. So these are close. These are close. So look with me, please, at the positive criteria. Notice, typical microorganism consistent with infectious endocarditis from 2 separate blood cultures. 2 separate blood cultures. So Staph aureus, Viridans streptococci, Streptococcus galeolyticus, which is formerly called Streptococcus bovis. Members of the HASSIC group. The HASSIC group. These are all gram-negative members of the oral cavity. HASSIC stands for Haemophilus, Actinobacillus, Cardiobacterium, Eikenarella, and Kingella. It's mercifully abbreviated the HASSIC group. And then the community-acquired enterococci, which again, you usually acquire through the GI tract typically. At least 2 positive blood cultures from blood samples drawn at least 12 hours apart. Now, there is an organism that can cause endocarditis called Coxiella burnetii that causes Q fever. Q fever is acquired from animals. It usually causes a pneumonia. Very often it's a subclinical pneumonia, but it can also cause endocarditis. Coxiella burnetii is very hard to culture because it's an obligate intracellular parasite. If you have an antibody titer against Coxiella burnetii, that is at least greater than 800 times normal, that would be a positive as well. Because some people could possibly have had Coxiella burnetii. They have antibodies to it. They're resistant to it, but they don't have an active infection. That's why you have the concentration. So positive culture, that's one of the major criteria. Second one is an echo shows you vegetations on the heart valves. Usually a cardiologist will need to do this. If you use, are any of you on Twitter? Well, X. Medical Twitter. There's a lot of garbage on Twitter, but I use Twitter because I'm part of this medical Twitter group. These cardiologists post these really cool echoes, and they'll say, "What is it?" And I'm terrible at reading these things, so I never get it right. But the cardiologists will sit there and say what it is, and then they'll argue with each other about what it is. The EKG ones are really cool because some of these people post these wild EKGs. And that's good because it helps me practice EKGs, but the echoes, I'm hopeless when it comes to echoes. Anyway, echoes, when you see a vegetation on a heart valves in an echo, they're thin and they do this. You get a vegetation on them, it's like, it's not this, it's, you got something on there, and usually it'll bounce back and forth. That's not normal. So it's pretty hard to miss. New valvular regurgitation. Okay, then the minor criteria: fever, 38 degrees or above centigrade, that is. Predisposition, you're in these high-risk groups. That's a minor criteria. If you have ulcer nodes, rough spots, rheumatoid factor, glomerulonephritis, splinter hemorrhages, any of those. Positive blood cultures that do not meet the major criteria. Or echocardiographic criteria, minor criteria that are met, so on and so forth. Those are your Duke's criteria. If they meet the Duke's criteria, you treat. You treat. Okay, any questions about the Duke's criteria? So usually to treat, you're going to kind of shoot very broadly with antibiotics. So if you have a native valve endocarditis, or you have an older prosthetic valve, they've had the valve for 12 months or more, that's an older prosthetic valve. You're going to go very broad. You're going to go ampicillin, sulbactam, and intravenous gentamicin. Both of these are intravenous drugs. Remember, sulbactam is a beta-lactamase inhibitor. Ampicillin is your beta-lactam antibiotic. This inhibits the enzymes that normally degrade this, so that increases the spectrum of the ampicillin. Ampicillin sulbactam is very effective against many gram-negative organisms. If the patient cannot tolerate beta-lactams, then you're going to give vancomycin plus gentamicin, but in that case, you will add ciprofloxacin. So that's for native valve or older prosthetic valve. What if you have someone who has a newer prosthetic valve? Newer means less than 12 months. Now you're going to treat with vancomycin plus gentamicin, and you're going to add rifampin. For a newer prosthetic valve. If someone has Staph aureus, you need to determine if it's methicillin resistant or methicillin sensitive. If it's methicillin sensitive, then you treat with Staphylococcus specific beta-lactams, drugs like nafcillin, oxacillin, or dicloxacillin. Nafcillin, oxacillin, or dicloxacillin. Dicloxacillin comes both in IV or oral forms. Nafcillin and oxacillin have to be given intravenously. If you have MRSA, you use vancomycin. And if you have a staphylococcal prosthetic valve endocarditis, going to use the same treatment regimen, but you're going to add on to it gentamicin plus rifampin. So essentially, you'll use this right here for staphylococcal infection with a prosthetic valve. If you have a streptococcal endocarditis, regardless of the type of valve, you will use ceftriaxone, usually. To give them ceftriaxone, usually for about 4 weeks. If you combine it with gentamicin, then you only need to give it for 2 weeks. And if they're resistant to, if they're allergic to beta-lactam antibiotics, you just essentially use vancomycin monotherapy. If you have infection with enterococci, then regardless of the type of valve, you'll use gentamicin. And if the enterococci are resistant to vancomycin, which Enterococcus faecalis usually is, you will use daptomycin, which usually works pretty well for vancomycin-resistant enterococci. What do you do if you have Coxiella burnetii? Coxiella burnetii, fortunately, is very susceptible to doxycycline. Standard dose of doxycycline, 100 mg twice a day for 14 days, usually will do a perfectly good job with that one. Last thing, endocarditis can be acute, in which it occurs within 2 weeks, or it can be subacute, in which case it will happen over a few months. And the viridans streptococci tend to be subacute, main causes of subacute endocarditis, which it says right here. Right. Any questions about endocarditis? Take a look at the case studies. Aaron, can you read case study 1 for us, please?
Two people coming to okay, never mind. Okay. Cardiology. I was struggling with that. Okay. One of them was 25-year-old Darren, who came in with fever, chills, and fatigue. One of the clinical examinations, his fingernails had splinter hemorrhages, and the palm of his hands had some erythematous flat lesions. There were also some track marks on his forearms.
Okay, spidey sense starts tingling. Track marks on his arm means intravenous drug use. And yes, your professor will learn to spell them these days. What's the main culprit usually with intravenous drug use for endocarditis? It's going to be Staph aureus, isn't it? Staph aureus. Splinter hemorrhages. If we have flat erythematous lesions, those are Janeway lesions. Fever, chills, fatigue, that's textbook infective endocarditis. Probably right side, probably going to have vegetation, probably going to have a murmur. Okay, case study number 2, Miss Grace, could you please read case study number 2, please? Auscultation. Yay, dentist 2 weeks ago. That's subacute endocarditis. Dentist, probably viridans streptococci. But she has a fever, splinter hemorrhages, Janeway lesions. That's infective endocarditis. So these are some examples of the sorts of patients who will have infective endocarditis. Does that help? All right, in the fleeting moments of today, We're now going to talk about sepsis. Sepsis means microbes have colonized the bloodstream. You have systemic inflammatory response syndrome. Systemic inflammatory response syndrome, that's the SIRS criteria. The SIRS criteria. 2 SIRS criteria have to be met in order to diagnose sepsis. These include either leukocytosis or leukopenia. We define leukopenia as white blood cell counts below 4,000 per milliliter. That's leukopenia. Leukocytosis is above 12,000. So if you're below 4,000 or above 12,000, that meets a SIRS criteria. Body temperature. It's either below 36 degrees Celsius, so hypothermia, or it's above 38 degrees Celsius, in which case you have a fever. That's a SIRS criteria. Third one, heart rate. Heart rate above 90 beats per minute. Tachycardia. Fourth criteria, respiratory rate over 20 breaths per minute. That's tachypnea. You need 2 of these. You need 2 of these, you have criteria for the systemic inflammatory response syndrome. If the SIRS criteria are not met, you should consider an alternative diagnosis. On the other hand, if you have a systolic blood pressure that's below 90, or if it falls 40 millimeters of mercury below the baseline, that's also probably a good reason for suspecting your patient has sepsis. With sepsis, because of the massive inflammation that your patient has, you get very leaky blood vessels, a lot of fluid leaves the blood system, and so the blood pressure crashes. Because if blood pressure crashes, your ability now to perfuse your tissues goes way, way down. So the severity of sepsis is measured by something called a sequential organ failure assessment, or a SOFA score. A SOFA score. Sequential organ failure assessment. The higher the score, the worse the patient's prognosis. So SOFA evaluates things like mental status, mean arterial pressure, respiratory function, and then blood levels like creatinine, bilirubin, platelet count. And the more those go outside the normal range, the higher the score. The higher the score, the worse your patient's prognosis is. So the hallmarks of sepsis are going to be fever, pretty high fever, and low blood pressure. The increased breathing will cause you to get rid of a lot of CO2. Because you're getting rid of a lot of CO2, you are using up lots of acid in the blood. That will cause respiratory alkalosis. Biggest things you need to do is get that blood pressure up. So you're going to use fluids and you're going to use pressors. Big one will be epinephrine. Epinephrine. Fluids and epinephrine. Most causes of sepsis are caused by bacteria. There are some that are caused by fungi, but you can see them in the minority. Common cause is MRSA, evenly divided between gram positives and gram negatives. If any sort of abscess popped and invaded the bloodstream, typically those will be polymicrobial. In which case you have more than one organism causing the sepsis. And I see that it is 9:15. I really need to move on. So if I need to say anything else about this, I will podcast it. We will move on to the next chapter on Friday. That would be pneumonias and things like that. Wednesday. Wednesday is cleanup. Now, if you've already cleaned everything up, then you don't need to come. If you need to clean anything up and hand anything in, then I will be there, but I won't be there at 7:45. I'm going to sleep in and be there at 8:30. So you need to come in, fine. If you don't, that's fine too. But if you have a mess and you don't clean it up, I'll know because I can see your plates. They're yours. You're going to lose lab points. And I know where you sit too. If there's a stain on your bench and you didn't clean it up, you're going to lose lab points. So I'll be there at 8:30. You can come or you cannot come. It depends if you've done your stuff or not. I would prefer